In this episode, we are having a conversation with a group of people who are involved with the PALOH study. So, Nick, tell me a little bit more about what are we going to be hearing. What is this PALOH study?
So, if you remember when Bill came in, he mentioned the PALOH study and he said it was something that he was really excited to be working on. It was kind of his passion. So, we're inviting today some people to talk more in depth about what the PALOH study is and how it came about. Apparently, 90,000 babies every year in the UK are admitted or assessed on a neonatal intensive care unit, and most will receive the antibiotic gentamicin, I think it's called, to protect against or treat infection. And 1 in 500 of those babies could be predisposed to like an irreversible hearing loss.
Okay.
So I think what they're going to talk about today is how the PALOH study could prevent that, and what they have kind of done in terms of moving towards a different test and how that could prevent this hearing loss in babies.
So are we having only professionals or medics or who's...
No, it's quite exciting. So we've got Dr John McDermott, who is the kind of the genetic consultant around and the kind of what seems to be the expert. I think he works quite closely with Bill actually, so that would be great to hear from him. We've got Rachel Corry, who is a kind of parent rep. So I think she's had quite a lot of involvement with the neonatal unit and has been involved with St Mary's for quite a while, and has got a particular interest in neonatal testing and the effects of that in terms of for the patient, the baby, and also the rest of the family. So it'd be really interesting to hear from Rachel.
Absolutely.
And then, which I'm really intrigued about, we have a lawyer.
Wow.
So we have Professor Margaret Brazier, and I'm just really intrigued about why a lawyer has had to get involved with this, and what that means and what that role is as part of the study, and what she's had to kind of either help on or develop. So I'm really interested about hearing from Margot and how she got involved. And then I think we also have another Rachel, who is the project coordinator. So she'll be able to talk to us about how you communicate a study like this, I guess, and make sure that, you know, you're getting the right communication.
It's so nice that there's a variety of people and we have representatives of them in the room today. And
it's brilliant, isn't it? And I think also it's the fact that it's Manchester again.
Yes.
So they're all from Manchester, they're all based in Manchester.
Yes.
And I think, if I'm correct, the PALOH study is coming out of Manchester, so it starts here. So that's what's kind of a nice connection for us as well.
It would be nice to have other people, you know, maybe responding to that from Manchester, what people in the street think about that.
Definitely. I think we definitely would like, it'd be good to hear from everybody and see. And whether that's kind of, I think it's not started yet, so it'll be really interesting once that starts to maybe go back and find out a little bit more about how it's being received by the patients in Manchester.
Yeah, fantastic.
Yeah, so it's quite exciting.
Forward, let's go.
It's a full studio. There's a lot of them, so it'll be interesting to kind of make sure
how we have space in this room.
I know, it'll get very hot again.
Okay.
So, welcome to another episode of the podcast series Rare. In this episode, myself and Mary Angels will be chatting to a group of representatives of the PALOH study. So we need to introduce ourselves because we're having a conversation today and it's quite a full studio. So we have with us Dr John McDermott, who is an academic clinical fellow at Manchester Centre for Genomic Medicine. Good. And Dr McDermott's research interest involves the application of genetic information in the acute setting to improve patient safety and patient outcomes.
Yes.
Would that be correct?
That is correct.
Great.
Yes.
And we've got Rachel Corry, who is a parent and advocate. And Rachel's son was born prematurely at St Mary's Hospital and spent around 7 months in neonatal intensive care. So we're looking forward to hearing more about how you got involved with the study. And obviously there's myself and Mary Angels.
Yes.
Facilitating.
And I'd like to know whether there is other things you would like to say about yourself that are not in your curriculum. Maybe that would be nice to...
Oh no.
Small little things.
Other things that I do other than genetics.
Yeah, exactly. Do you have time for other things?
Well, to an extent, yeah. I have always been around Manchester.
Okay.
I studied here and then worked in the genetics department here, and now I'm a registrar there. So a lot of, I suppose, this is still about genetics rather than about me generally, but I think how can we apply genetics over kind of the Greater Manchester region. So how can we use genetics when you go and visit your GP or when you go to A&E rather than traditionally how we do it, so up in the genetics department with kind of classical rare disease.
Brilliant.
Nice.
Excellent. Well, my day job is I'm an occupational psychologist, and I work in human factors and do a lot of stuff about human error. So I always joke that we spent such a long time in neonatal care that I had plenty of time to watch what was going on and what was done well and what had improved. So it was quite interesting from that perspective. I'm also I've had 4 children. The eldest is 9, and we had twins who were born very prematurely, and unfortunately they died. So I'm very much involved in the fetal and maternal research as well, to see if we can I can input into finding ways to stop stillbirth and miscarriage and things like that. So
you haven't really left St Mary's.
No.
I know the feeling. Yeah, just keep coming back, bouncing back.
We're always finding a way to come back. It's World Prematurity Day on Sunday, so and they're having a celebration on the Friday. So we'll be popping back, and they say it's nice to see them when they've been there and so poorly and so small. Now he's 4 years old, so he's running around and being cheeky. So
good.
Yeah, it's nice to. I think they say it's nice to see them growing up and looking well.
Oh, it must be. It must be such a treat to be able to come back and to kind of catch up with everybody.
Yeah.
Can I ask about your profession? You said you're occupational psychologist. This is not very. Is it quite new? There's lots of occupational psychologists in Manchester, or
it depends really. I work in safety critical industries, so things like anything from. I started off with the Ministry of Defence, doing flight trials, looking at the design of new aircraft to make sure that they were designed in a way that people could operate them quickly and effectively. Then I went on to work in nuclear power stations, looking at the control room layouts and things like that. And I've worked in transport and various other high hazard industries. So in fact, there's a growing area of human factors in medicine. So this is interesting for me as well from that point of view, because there's always ways that things can be improved, and reliability and minimising error. So it's both a personal and a professional interest.
I was going to say, before you had your babies, do you think you would have come into this area?
No, probably not. Just because a little bit of experience goes a long way. You experience something and you think, well, I think, oh, that was interesting. That was done really well. I think this could have been improved, and that's how my mind works anyway. So yes, it's just kind of built on from there.
I think that's really important, isn't that lived experience? I think if you've got that lived experience and you can put that input back into something that you've been through to either improve it or just to kind of have an influence over that area. I think it's really important.
And with the prematurity, and particularly this study, there are so many things that premature babies and full-term babies who are poorly, but particularly premature babies go through so many different potential life-threatening issues before they can come home. And if with this study, this is one way of intervening so that we can minimise deafness caused by this particular antibiotic. So it's one less thing for them to encounter, because there are so many. So let's do what we can to try and improve survivability rates and quality of life for these babies.
Yeah, and having Rachel's input just from a different perspective has been so important to us throughout the project, and has really kind of helped us to get to where we are now.
So tell us
about the project.
Tell us, because we've been reading a lot, but I was going to read something out about it, but I'm actually not. I think it'd be really much more kind of useful for you to tell us about it and how it came about and kind of your involvement. Yeah,
so the Payload Project stands for pharmacogenetics to avoid the loss of hearing. So basically there's antibiotic called gentamicin, which is a type of aminoglycoside antibiotic. It's really, really commonly used, and it's really, really cheap, and it's very effective. It's used around the world for lots of different indications. If I gave anyone in this room a huge dose of gentamicin over a prolonged period of time, you'd probably become deaf. It's just one of the side effects. But it was recognised in the kind of latter part of the 20th century that certain families appear to have a predisposition to this, whereby just one dose of aminoglycoside antibiotic could make them profoundly deaf.
Right.
And it was recognised in, I think it was 1993, that all these individuals in these families shared a particular genetic change. We call it the RNR1 change. Okay, so that was recognised in 1993.
Right.
We knew that if you received this antibiotic, you became deaf during the kind of neonatal and childhood periods. But the problem is that we give that antibiotic to about 90,000 sick babies in the neonatal unit every year. And if you think they've just been born, to test for that variant traditionally takes about 2-3 weeks to actually get the result. So,
And it has to be, you had to have given them immediately.
yeah, it's got
Almost.
to be...
It had, so you couldn't have waited.
No,
No.
So children with cystic fibrosis, we know that they're going to get antibiotics. So we will test those children, and if they carry that variant, we'll record it as an allergy, for example. And that's fine, because we know that they don't need antibiotics then, but they might need them in the future. The problem in the neonatal unit is that you have to give antibiotics within an hour. So me as a geneticist coming along saying, whoa, wait 2 weeks before giving the antibiotic. Yes. You can't do that, because they need the antibiotic potentially to survive. So we asked ourselves the question, probably about 3.5 years ago now, could we develop a genetic test that could deliver a clinically relevant result in a clinically relevant time frame? Could we develop a genetic technology that you could use by the bedside to give you an answer then and there that could mean you could give a different antibiotic?
And was that in Manchester?
That was in Manchester, yeah. So we collaborated with a spin-out from the University of Manchester called Gene Drive, and we developed a piece of technology where you take a little buccal swab, a little cheek swab off the little baby, put that swab into our machine, and in 25 minutes it tells you, have they got that genetic variant or have they not got that genetic variant? And a lot of our work has been kind of validating that, and we're pretty happy that it is validated and it works. The kind of real core of the Payload Project is, can you use that test in the real world setting? When you've got a knackered nurse at 4 a.m, can she use genetic information to change management of a patient?
Well, this is what Professor Bill Newman was telling us
Yes.
about, and it's connected to not so much about the technology, it's more about the human side of the effect in the human side, the families, the professionals that need to be involved there. And how are you in this rhythm? How this is?
So, I mean, for us, one of the kind of frustrations about, so I meant pharmacogenetics is how you use genetics to optimize medicines and optimize how we manage patients. One of the frustrations in the field is that, so we know that these variants are out there, and although they're kind of rare on an individual level, they're really common. So 1 in 10 people don't respond to codeine because of a genetic variant. 1 in 8 people don't respond to a commonly used antiplatelet medicine called clopidogrel. And we know about that. We've known about that for ages, but we don't apply it. So a lot of our feeling is that a lot of our work is factored around how we actually apply that in the real world setting to improve patient outcomes. And certainly, after spending years and years thinking about this, if my mum or dad went into hospital and needed clopidogrel because they'd had a stroke or a heart attack, I'd want them to have that genetic test. And everyone you speak to does that. When we do our PPI project, you say to people, we know about this, should we do the testing? And everyone goes, well, of course we should be doing it.
And I think in theory, that's absolutely right. But when you are, I think the tricky bit must have been when you are a new parent and you've just had this brand new baby, or you're in a situation where somebody's, very poorly, and then somebody's coming in with another factor that you've got to think about and make a decision about. And, I had my children at St Mary's, and my youngest was in the neonatal, not for very long, but I'd had a cesarean as well because of my genetic condition. I have to have a cesarean. So I had to have a surgical, so I was asleep, so I woke up and she was taken away, and then I kind of first saw her in the neonatal. And there was decisions that had to be made, not huge ones if I'm fair, but decisions. And it was very difficult to make those decisions with quite limited information, because it has to be limited, because it has to be quick. And I guess that's where you came into it, Rachel, in terms of...
I mean, from a professional point of view, I'm quite interested in the way that this test is incorporated into the usual checks that need to be done. I mean, for example, when Hugo was born, it was 4 hours before we could see him because it took a while to stabilise him and do all the different tests. And in fact, I was bizarrely induced with Hugo at 24 weeks because I had an infection that they couldn't get rid of at all. So Hugo would have been given gentamicin because he was it was a case of getting him out before this infection potentially kills him, really. So he would have been one of the people who had gentamicin, and luckily we don't have that genetic variant, so it all fine, but we could easily have had. So it's really important if there's any way of testing for these things before we give them appropriate medication. It's brilliant.
Yes, definitely. It's interesting.
I think there's quite a lot of ethics issues coming at the table, and I'm thinking about the different voices and the different, maybe if you are a parent or a professional or you are interested or you had a history of having an illness in your family, even might influence the way you see and perceive things. But shall we invite more people at our table? Maybe we can pause and...
Yeah. That would be great.
Yeah. We are having a conversation with some of the team from the PALOH study about applying the law and ethics when it comes to genetic testing.
And we also have here with us in studio Rachel Mahood, and you're a senior clinical trial coordinator at the university, and you're part of you're the Payload Project.
Yeah, I'm kind of the project manager for Pilar. So I've been involved for the past 2 years. Potentially. So my background's I'm a research scientist, but I then, after having done my PhD in kind of molecular biology, I moved into more clinical translational work, and for the last 2 years I've just been working on Payload pretty much all of the time.
Well, looking forward to hearing about your involvement.
Thanks.
And we also have with us Professor Margaret Brazier, and your work has covered the understanding of the regulation of medical practice and medical ethics.
And medical law as well. I'm a lawyer rather than an ethicist.
I was just about to go into that. But that's great. The analysis of how ethical considerations can or should be reflected in law and the mutual rights and responsibilities of doctors and patients.
That's what we try to do. Whether we succeed is another matter.
But that's your main...
Yes.
Would you call yourself a lawyer?
A medical lawyer.
Yeah, first.
Yes. And I work very closely with the ethicists. We have a centre at the university and we work together, which is really good because we bring different skills and we have different connections with the medical school and medics. And I think it works much better than one person thinking they can do everything.
But it's interesting that you're putting an emphasis here rather an ethicist. What's the big difference for people that we don't know? The big differences in between a medical lawyer and an ethicist?
I think that the ethicists address what ought to be right. They look at philosophy, moral philosophy from generations ago and try to apply it today, and they're looking for the ideal. Lawyers are perhaps a bit more, get their hands a bit more dirty and are a bit more practical, so that one of the questions I will always ask is, how is this going to be done? What's going to be done? What are the possible consequences? Because very often you can present a beautiful tale of how things ought to be. And my former colleague, who was our senior medical ethicist till very recently, John Harris, used to describe me as the centre's wet blanket. They'd produce these brilliant ideas and I'd sit there and say, yeah, how?
Well, the mood hoover, as my daughters say. Come in and change it. So in terms of the Payload study then, how did you become involved and what was your particular kind of interest?
Many, many years ago, I taught a young master's student who was a medic but doing a master's degree in healthcare ethics and law. And he was called Dr Bill Newman. I heard a lot about him over the intervening years, and then I got an email saying that they got these questions that had been raised in relation to ethical approval and the Health Research Authority, and could he and his colleagues, John and Rachel, come and have a chat?
And what were your initial thoughts when they described the Payload study to you? What were your initial kind of concerns or...
My initial thought was not a very professional thought, but just looking at what was being done and the huge importance of it. And I thought, oh dear, this is nitpicking again. You can't possibly have all these problems with something that looks so good, that could have so many benefits for children and their families. But of course, the law is designed to deal with everybody, and not everybody is good and well-intentioned. So I think the next thing was really to look at the sorts of questions that were being raised about it, and to work through them in various ways, both with the Health Research Authority, with the Human Tissue Authority, with colleagues in the hospital, and find a way to implement what the laudable desires of what was being done in conformity with the law and in conformity with ethics, because we know, and history teaches us, that good ends are sometimes abused by bad means.
Yes. Yeah. And that must be a real challenge, to hear a really good idea, but then to try and kind of work with that idea so that, and actually in the end it's the best thing, because you actually kind of proofing it, and to make those mistakes not happen in some ways, rather than just kind of go, it's a great idea, just go with it.
I think that's right. I also think that even now, even though there's so much more public information about genetics, and I'm using that word deliberately because it's the word that the press and the media would use, it gets a bad press. A bad story is actually a better story for the media. So something going horribly wrong, parents having their rights and responsibilities trodden on, is a much better story, I'm afraid, than PALOH. I hope that can be redressed.
Absolutely. My background is within the media and broadcasting, and John and I were talking about this earlier, and it's something that I'm personally interested in terms of how the media presents genetics. And you're absolutely right, it's always sensationalised. They're looking for mistakes, they're looking for families to be victims, and we almost watch this play out, don't we, in the media, and nobody really knows how robust things have been behind the scenes, or what's happened, and I think to alter that portrayal is really important for somebody like myself, who's a patient essentially, and who's coming in and discussing genetics and trying to kind of get my head around it, and the media often don't play a great part in portraying that.
And in a way, the media, when it's a bad news, it stays for us forever, for a long time. So we need how many times to readdress that, to be able to unbalance one bad press story, because I don't know why we respond to bad stories in a different way than nice
The positive stories.
Yeah.
And Rachel, as the project coordinator, how have you found that in terms of talking and promoting the study and kind of getting people's involvement? Have you found that's been difficult because of this kind of...
It has been surprising. I think everyone's touched on it, in that on the surface it seems like such a great idea, and everyone is, whenever you mention it, everyone thinks, oh, of course, why aren't we doing this already? But as with all studies, you've got to go through various processes, and we went to the Research Ethics Committee, and they were very, very positive. But there was these questions about the legality of it, because it's not really been done before. And we were looking at the Human Tissue Act, which was written in 2004, when it wasn't really thought that we would be able to do genetic testing so quickly. So this idea of not having a chance to get consent in advance hadn't really cropped up before. So that was what was really interesting. But yeah, I think everyone thinks it's a great idea, but we just needed to make sure that we weren't breaking any rules. So that's why we spoke to Margot.
So would it be that, well, I think what I've been hearing through in the other interview and now, that is almost the technology, the science goes faster and faster than our capacity to regulate things, or our capacity to sometimes even understand things and to know whether we have choices, and if these choices are as a mother or as a parent or maybe as a professional.
I think that's right. I think especially in this scenario, that was what we found.
I think there are always problems where you're getting consent, or whatever form of consent, whether it's deferred or not, from somebody other than the individual. That the model, so to speak, is the competent adult who's got full information making a decision for herself or himself. When you're talking about decisions that you have to make for very tiny babies, sometimes babies you haven't even seen, it's a much more complex question, both emotionally and socially, for the parents and for the law, because people disagree. I'm sure there will be somebody who says, I will not have this test on my child.
Absolutely.
My child must not be touched. And there are all these tragic cases too, which get a lot of attention in the media at the moment, about disputes between the professionals and the parents, where the parents want something that the professionals deeply feel is wrong. The parents are equally clear that they are right. And they're not directly related to the PALOH study, but they all feed into the debate on issues like that raised by this study.
And does it also, I don't know if this would be correct, but would it also raise issues with any adults that have that are deaf, that have the condition? Have you had a response from that community in terms of this type of testing or this, and the language used around that, you know, the language of it's great because we're actually, you know, preventing children from going deaf, or adults, you know, or being deaf. I know the deaf community is quite a strong community, and I just wondered whether there's been any kind of comment from them around.
For this particular variant, I wouldn't say it's been any real negative discussions. We've involved patients who've had this testing done because we were collecting samples to validate our test, and everyone that I've spoken to has donated, but very happy to donate a sample so that we could test it in our new system.
Right.
And they were always very much interested in, this is a great idea. So I think for this particular variant we haven't had that challenge, because I suppose it's not people who, I'm not sure what you think, John. John's
we might go back to that later.
John's the doctor.
Well, I mean, I don't know, John, whether that is something. I'm basing it on my particular genetic condition and living with a condition that you don't see is an issue. Mm-hmm. So you see it as something that is part of your identity, and it's okay to have, whereas it might be perceived by other people, particularly maybe the medical profession, that that's something that definitely needs to be sorted out with you know, a new scientific discovery or a new kind of pharmaceutical drug. And I just wondered, it might not be the case with this particular, but I just wondered in terms of whether there had been any discussion around that.
So this work was initially funded 3.5 years ago when we got a little bit of money to first develop the test by Action on Hearing Loss. So right from the very beginning, we made sure that we were kind of liaising with the various charities and the various stakeholder groups, and the PPIE work throughout. We've made sure, we've tried to do this with every project we do, from the ground floor, get the opinions of the stakeholders, the people it's going to affect. We do that for a number of reasons. Number one, because it helps us develop a better technology at the end of it, a better management approach. But also, it's really, really important to show when you are going for these big grants that you've thought about this, and not in a tokenistic way, but in a way that is actually kind of taking into consideration different people's opinions.
Interesting. That's really good, because we were wondering when we talked with Professor Bill Newman last time whether we didn't ask about the community and how you are connected to the community. Yeah.
One thing I think that is really very heartwarming now is the enormous change that over 30 years I've seen in the way in which particularly medical professionals work in cases like this. I know I sat on the Central Manchester Research Ethics Committee longer ago than I care to remember. And I remember asking a couple of questions to then very distinguished consultants at MRI. Had they consulted patients? Had they talked? And they looked at me as though I was completely bananas. Why should we? And so I think the communications, first of all, it's a part of medical education now, and I think it's much better. And I think we have, with some exceptions, I'm afraid, a group of people now who are leading projects such as the PALOH, who are very committed to working in partnership with other professionals and with the patients and the people who are involved.
Would you say that there's been shift because of the families, the patients, or it's been in the education of it, or other, maybe not medics, being involved in education? What would you attribute to that? Or
I think it's a combination of factors. I think it's that we draw our senior medics now perhaps from a slightly different strand of society than was the case 30 years ago. I think the work of various patient groups and lay people becoming involved in medicine is important, and the work of other professionals. And again, when I first sat on the Central Manchester Ethics Committee, there was a project and we said, could we meet some of the nursing staff? And it was sort of, why?
Yeah.
And how do you think this PALOH study might influence your work, Margot, moving forward and your next kind of...
Well, I think it'll influence the work of my colleagues more, because I am retired now, and the work I'm doing at the moment is actually going back into history and looking at the relationship between medicine and law from a long time ago. But again, I think I've noticed very much in the projects that we've done and my colleagues are doing, we again involve the people who are actually at the coalface rather than being these grand lawyers and ethicists who look at the picture and don't necessarily know anything about it themselves.
Would it be that there are more women in the profession, one or the?
It's interesting to see that in our centre we are predominantly women. And we had a conference which was open to everybody a few days ago, which was looking at different developments in reproductive medicine, artificial wombs, womb transplants for men. And there were 3 men and nearly 40 women.
Okay.
So there certainly are far more women working in this field from both law and ethics.
Yeah.
Whether that's a factor, history will show.
Yeah, interesting.
Really interesting.
We hope you are enjoying the podcast so far. Please subscribe, rate and review. Continue to follow our conversations where we discover that rare means different things to different people.
John, I wanted to ask you, because it's something that we touched on earlier, about your role, you know, in terms of genetics and how you're trying to embed that a little bit more with your colleagues around in A&E and kind of what's the perception of your position?
Yeah, so I suppose it goes back to what I mentioned before, the fact that in genetics we feel that we've always had lots of data to suggest that if you did implement it in everyday healthcare, you could really improve outcomes and you could really improve the people's quality of life. But we've never done that. And so the vast majority of my colleagues, quite understandably, because they don't have really any interaction with genetics, is that we don't really kind of implement what we do. We see people with rare disease and with cancer, but other than that, it's not really relevant to acute physicians. It's not really relevant to other physicians in a really kind of tangible way. And I suppose what we're trying really hard to do is to, number one, look for those opportunities where we can apply genetics to improve outcomes. And part of that is going out and meeting different specialties and talking to them and turning up and knocking on the door and saying, you need to be using this. And it is working slowly. And so we're doing more of these translational projects, both. So the Payload Project is the first of them, really. But then it's relevant in the stroke community for people who take clopidogrel. It'll be relevant in general practice and in emergency medicine. So yeah, it is becoming increasingly relevant, but I'd say 50% of the work is just going out and me trying to convince people that they should be using it.
Can I ask one thing for everybody who's listening to us? So what do you mean when you say this translational process?
Yeah. So I suppose translational research is more about, it's kind of that old adage from bench to bedside. So it's how you take the data. So let's say one of us has a particular genetic change, which means that you're not going to respond to codeine. So you go into A&E, you've hurt your leg, you're in pain. If they don't know about that, and you've had some paracetamol, they'll probably give you some codeine. The translational aspect of that is how do we implement services on a kind of population level that mean that won't happen, that person will get a different analgesic medication. And that's kind of very basically what translational research to a point is, and it's measuring the outcomes of that research.
This is a very basic question. Could that potentially mean that could almost be part of our medical record? So when I go into my GP, that disposition, or that would be on there, my genetic almost kind of...
Yeah, and so that's a huge other portion of my work, looking at how you integrate genetic results with medical records, and how kind of your GP would use that information, because I spend my entire day looking at genetic variants and I absolutely love it, but I can tell you my colleagues certainly don't, and they don't want to have to interpret the data. It's about creating systems, creating methodologies that does it automatically in a safe way, in an effective way.
That could really cut down quite a lot of time. There's a real gap between GP services often and getting to genetics or, you know, getting to the department where you need to get to. And I think bringing that together will be a really interesting move forward.
Yeah, and that is a huge portion of our work, just trying to speak to our colleagues who might normally have literally zero interaction with genetics for their entire careers, trying to speak to them and say, well, actually, more and more it is increasingly relevant to you and your patients.
Yeah.
Is it about tailoring? Tailoring is the word? Tailoring more medicine for individuals somehow?
That's exactly what it is. So we've known for hundreds of years that certain people don't respond to medications like other people, and we've kind of just always shrugged our shoulders and gone, oh, well, that's just bad luck, isn't it? Whereas often it isn't bad luck. There's a reason there in someone's genetic makeup that explains why they don't respond to a medication. And I suppose our work is about filling that gap and making sure that doesn't happen. It's not going to explain all the variation, but it'll go some way to explaining a good proportion of it.
And I think it's going to be really reassuring for our listeners, and it definitely is for me and my family, that there is this team of you. I think none of us see that. You know, we just kind of, we hear about a study and it doesn't really kind of connect that there would be somebody like Margot involved, and, you know, and there would be Rachel involved. And that is the voice of different sides of kind of the journey, really. And I think that's really reassuring for us as patients to start to kind of think how robust. And it's not just, as we were touched on earlier, that the media might just think that this just come from nowhere and now everybody's being tested and it's all kind of, it's just really reassuring to think of this background and this kind of ethics and the law that's kind of guiding these studies.
It's practicalities as well. One of my first questions was, if you're going to take a mouth swab from a very small baby, what happens? Are you likely to dislodge the ventilator tube and stop them breathing? Because I mean, Hugo a number of times pulled out his own tube, and it was a proper emergency of everyone getting together and trying to sort him out. So, but talking to the research nurses and the practitioners who actually do this, they said no. This we use this method to do different tests, and we're pretty sure that there should be no problem with that. So it's all these little things that, as a parent, having lived through the neonatal experience when things go wrong, and you're very aware of how potentially unnecessary intervention can cause problems. It's been really helpful for me to know that these guys who have they've taken on board my questions, and they've provided answers which satisfy me that no harm would come to this baby. Any baby tested is not going to be disadvantaged in any way at all. And even if you say you don't want, parents say that they don't want the results included in the study, again, there will be no disadvantage to the baby there either.
Yes.
So it's certainly being involved and being able to ask these questions has certainly given me peace of mind that I would be more than happy if we did it all over again, which we won't, for any baby of mine to be involved in this study, because I have no doubt that that the babies will be safe and it won't affect them in an adverse way at all.
And it's go on. No, I was just saying, it's very quick. I was just going to say that it's keeping that patient, which is the baby, at the very centre of everything, and all the factors around that, which can be hard. You can forget that quite easily. Yeah. Even as we're talking, I'm bringing myself back all the time to the fact that the patient is the baby that's going to have this test. And
I just wanted to say that this is very powerful to hear from you as a mother, but also as a person who's developing your profession in this way, which will influence other people. So I think I just wanted to say that. It's powerful as a mother.
Yeah, and especially that time in the neonatal, which is a really, interesting time.
Yes. Interesting, harrowing.
All of those words, and then to be part of a study can sometimes feel, oh no, I just haven't got the time or the space. But
talking about time,
so we just have one. You can explain, Maren, just because it's.
Well, we have one big question, small question for each of you. That you understood the question?
No, you.
We were wondering about whether you could define for us in your own ways what is rare. And
so if we asked Bill this actually, and it was really interesting. The response, we won't tell you what it was, but there's no pressure. It was just to kind of we're asking each of our guests, when we say rare, what is the kind of almost first thing that you think of, or what is whether that be an image, or when we say rare, what would be what would you think of if we said rare?
Oh gosh, I think I'd have two sorts of thoughts which are probably contradictory. I think I would think that it had to be something like 1 in 30 or 40 at least, so rare in terms of its incidence. But also, and I don't know why, it's probably just through reading a little bit, I would include in what I'd regard as rare disease in this context the seriousness of it, which is probably linguistically not justifiable, but so that it wouldn't just be that, let's say that any child I might have had a 1 in 50 risk of having red hair. I don't think I'd regard that as serious, although I am very much aware that in previous times having red hair was seen as an indication that you were a witch. Yes. So it's something that is a relatively small number of people, and with a fairly large impact on those people who have or might carry the disease.
So I suppose when I think about rare, it's related to kind of genetic variation, I suppose. So we all have an unbelievable amount of genetic variation. So compared to the reference genome that was developed during the Human Genome Project, we all have 5 to 6 million different letters change compared to that reference genome. Now, some of those changes can cause what we've typically called rare disease, and some of those changes do hardly anything at all. But when I think about rareness and that variation, it's actually, we all have variation, we're all rare in our own way, and it's almost the usefulness of that variation and how we can use that to help people going forward. So it's not just related to what we traditionally call rare disease, but we all have these rare variants that could be really important for us.
Yeah, I don't know if I can add anything different really. I think rare, I think I see it as quite special, which is a positive thing. But the only negative thing about being special is that if you have special requirements or things that need to be taken into consideration, if very few people have the same thing, excuse me, then you're going to find it harder to get them. So yeah, that would be my gut instinct.
Yeah, nice.
Thank you, that's nice.
Perfect. You can still think, Rachel.
I don't think I've got much to add really.
No.
I think rare is, it's interesting, isn't it? Because if you think of all the people who've got different rare disorders, if you add them all up, it doesn't become very rare anymore. So,
Well,
That's exactly kind of the origins of the podcast, really.
Right.
No, I was thinking I'm trying to collect today's rare between contradictions in the language or a variation or something special blue in a red group, and if you add everything up, maybe it's not rare anymore, which is interesting. Yeah.
Thank you so much. That was really, really interesting, and yeah, it was just great to hear all of your kind of different perspectives and involvement and how the future might look for the study and for all of us really, which is... This podcast has been made possible by our brilliant team.
Rona McLeod,
Ramona Moldovan,
Jay Roach,
Maria-Angels Ferrer,
Nicola Garda,
Fiona Ulf,
Nick Jordan.